Hello and welcome to our podcast series by PacesDiaries.uk. This podcast is focused towards catering all the necessary information about MRCP UK PACES examination for those who are preparing for the PACES and also for those who wants to know what MRCP UK PACES is all about. I'm your host, Dr. Sophia ALDRINE, and today I would like to introduce you all to our guest who is none other than Dr. Moses J. Wesley. Welcome again to our podcast series, Doctor.
Thank you so much, Dr. Sophia. It's such a pleasure to be here in the podcast series, and especially where we are catering the needs of all the PACES aspirants and candidates. It's such a pleasure and joy, especially to just talk about the subject and deal with the subject and dwell into the neurology, which I passionately love from the bottom of my heart. Such a pleasure to be here again. Thank you so much.
It's extremely our pleasure to have you today with us to discuss yet another topic in neurology. So, Doctor, today we continue to discuss about neurology station and some of the common topics for PACES and their approach. So, a topic for today is cerebellum.
Okay, that's a great topic. Yeah.
This is one such topic where candidates either sail through, if I have to quote it in your words, or fail terribly. So, what's this issue with the cerebellum and why it haunts some candidates?
Yeah, the problem is many of the findings of cerebellum can overlap with so many different diagnoses. For example, if you're going around and you are seeing an incoordination, this incoordination can come as a part of Parkinson plus syndrome, like, right, MSA. This incoordination can be a part of a Friedreich's ataxia. This incoordination can be a part of some sensory ataxia. This incoordination can be a part of multiple sclerosis. All right, this is something you need to have a thorough understanding of what a cerebellum is and how to go ahead and make a diagnosis, which we are going to see. The other problem is many people doesn't know how to approach and examine the cerebellar system. That's another issue. And the other thing is lack of basic concepts and complete lack of knowledge of cerebellar anatomy. Just few things. Nobody is expected to know the neuroanatomy at the level of a neurologist. Just the basic anatomy is needed to come to a conclusion what it is, where it is, how to localize, and how to diagnose.
Yes, doctor, definitely. That's for sure the actual fact that is happening. So in neurostation, we either get the command to examine the upper limbs, lower limbs, or the cranial nerves. So what are the steps that should be followed in examination to identify that the pathology is in cerebellum?
Yes, that's a very good question. The command you will get in a case of a cerebellar examination is, this gentleman has some difficulty in walking. Would you like to examine his gait and proceed however you want? Then you can. This gentleman has some difficulty holding objects, or this gentleman has some rare occasion difficulty in speaking as well. All right. So cerebellar examination. So how you are going to approach? Go ahead, use the sanitizer, just sanitize your hands, wash your hands, then wish the examiners, introduce yourself to the patient. And when you are introducing yourself to the patient, notice a scanning or a staccato speech. Right then and there itself, you have to notice. Next, the next thing I would suggest is gait. Go ahead with the gait, nothing else. Ask the patient to walk with him. Don't ask him to walk and fold your hands and stand few feet behind and watch what's going to happen. No. That's not the way you have to approach a PACES examination. You have to walk with the patient. All right. It can be a cerebellar ataxia. It can be due to ataxia, which is basically due to some sensory involvement, like a dorsal column involvement. So you have to do rhombics, check tandem walking. All right. This rhombics can be done with eyes closed and eyes open as well. Okay. I'll come to that in a bit. Then once you've done that, make the patient sit. Then divide into head, hand, and legs. All right. Once again, I'm repeating head, hand, and legs. See the head, look at the face, look behind the ears and scalp for scars. Many will ask why I have to look for that, because it can be a recurring CP angle tumor. Look for scars. Look at the back for scars. All right. Then look for broken pursuit in the eyes or any abnormal saccades. And then look for nystagmus. Be very careful when you're checking for eye movements. Ask the patient to keep the head straight, or better, use stabilize the head gently over the eyelid, stay at a distance and check that. Once you have done that, I want you to examine 4 cranial nerves. There is cranial nerve 5, cranial nerve 6, cranial nerve 7, cranial nerve 8. All these cranial nerves can be affected as a part of CP angle tumor. So you have to check them. Next, your face is done. Now comes the hands. Outstretched hand, tremor. Check for hypotonia. Check for any intentional tremor. Finger nose test, dysdiadochokinesia, and rebound phenomenon you can offer. Don't make the patient to hit his face with his one hand and get into trouble in PACES examination. Once you're done with the hands, the next thing you have to go to the legs. In the legs, you are expected to check heel shin test, posterior column sensation, especially to rule out subacute combined degeneration or any dorsal column involvement, pendular knee jerk, check for ankle jerk, and plantar. Done. These are the steps. Once again, to avoid confusion, I'll tell you, you're just going to go ahead and introduce yourself and all the rituals of hand washing and then greeting the examiners. Speak to the patient here. Hello, my name is Dr. Moses. I'm one of the medical doctors here. I've been asked to examine. Is it all right with you? Then if he has some cerebellar lesion, the speech will show you. There is a scanning staccato speech. Then check the gait, tandem walking, rhombex. Then in the head, look behind the ears and scalp for scars. Look for broken pursuit, abnormal saccades, nystagmus, and cranial of 5, cranial of 6, cranial of 7, and cranial of 8. Look at the hands. Check for tremor in the outstretched hands. Check for hypotonia, intentional tremor, finger nose test, and dysdiadochokinesia. And offer to look for rebound phenomenon. And then look at the legs, heel shin test, pendular knee jerk, ankle jerk, posterior column sensation, and plantar. Any one posterior column sensation quickly. If you do that, your cerebellar examination is complete. You will not only be able to present the case properly, and whatever differentials, you will get it right away by the time you finish your examination. All right, hope that helps.
This could not get any further simplified. Like just follow the steps and arrive at the diagnosis. This was a much more simpler and a very detailed guidance to our candidates. Thanks for that, doctor.
Yeah, absolutely. It's my pleasure. Yeah.
So main thing the candidates tend to forget is the drugs, or I would say the medication history as the cause of cerebellar dysfunction. So can you throw us some light on the drugs and its contribution to cerebellar dysfunction?
Yeah, that's very important question. Like couple of drugs that can cause cerebellar dysfunction. Okay, you don't need to remember all the drugs. Just remember a couple of things. One common drug that we use is day-to-day life in epileptics. This phenytoin can cause. Lithium is another drug. Carbamazepine is another drug, and phenobarbital is the other drug, and some chemotherapeutic drugs. Just remember 5: phenytoin, lithium, carbamazepine, phenobarbital, and chemotherapeutic drugs. So drug-induced cerebellar degeneration is a common thing. You can see, even I had a patient last week. So you should be aware of it. This comes in handy when especially you are in a clinical consultation station, that is station 2 and 5. Drug history is very important. That's why we advise people to go ahead and ask about what are the drugs you have ever taken and you are taking right now. That's extremely important. All right, hope that helps.
Yes, doctor, totally. So what are the causes of cerebellar syndrome, doctor?
Okay, that's a very valid question. What are the causes of cerebellar syndrome? So candidates has to diagnose. And before that, I would like to shed some light on cerebellum and its anatomy. Just very little, I'll tell you. All right, the cerebellum has a cortex. It's a 3-layered cortex. Okay, it has its folds and grooves. The folds are called folia and the grooves are called fissures. And it has 2 hemispheres, All right, and the central part is what we call as the vermis. Just remember this. The cortex, which is 3-layered, 2 hemisphere, and the central part is a vermis. Done. Then there are cerebellar nucleus. All right. Your dentate nucleus, your emboliform nucleus, your globose nucleus, and as well as your vestigial nucleus. Then comes to division. If you divide the cerebellum, it can be a spinocerebellum. All right. It involves in regulating your muscle tone. Then your posterior part, your neocerebellum. This plays a crucial role in coordinating voluntary movements. Then comes your vestibulocerebellum. Name itself says vestibular. What it means by that? Like maintenance of your posture and balance. All right. This cerebellum has many major pathways. I'm not going to go into the detail of it. All right. So after examining what are the cause, how you are going to localize the lesions of cerebellum, that matters a lot. So you should know the anatomy first. You should do the examination first. If you have done this two properly, then knowing the diagnosis is cakewalk. All right. What could be the most common cause? A demyelination. Look for INO. By the time you're doing an eye movement, if you're seeing an internuclear ophthalmoplegia, you can offer a fundoscopy to look for optic atrophy. Then it's a demyelinating lesion like multiple sclerosis. In India, most common thing, alcoholic cerebellar degeneration. All right. Then in that case, you have to offer to check for stigmata of liver disease. Then the other cause can be a Friedreich's ataxia, young gentleman with cerebellar findings. Friedreich's ataxia and spinocerebellar ataxia, never ever forget. All right, these two are very, very important. All right, Friedreich's ataxia and spinocerebellar ataxia are two very important lesions when it comes to a young man with cerebellar syndrome. Also, demyelination. Then, along with that, there can be some posterior fossa lesions, and then it can be drug induced, and then again it can be a CP angle tumors. CP angle tumor are four. You remember by the name AMEN, that is amen, means your acoustic neuroma, your meningioma, your ependymoma, and neurofibroma. These are very important things. Then some causes like reversible causes like drugs, alcohol, and also hypothyroidism, vitamin E deficiency. All these things can cause cerebellar syndrome. So these are the commonest differential diagnosis. Sometimes in a case of a patient who is having some malignancy, and post the malignancy or during the course of malignancy is developing some cerebellar syndrome, then it's a paraneoplastic cerebellar degeneration. All right, I hope that helps.
Yes, doctor, definitely. And as you just mentioned, paraneoplastic cerebellar degeneration. So this is again another cause of cerebellar dysfunction. Can you please
Exactly.
enlighten? Yeah, can you please enlighten our candidates on this topic, doctor?
Okay, paraneoplastic cerebellar degeneration. Yeah, it's a very important topic because once the case has been kept in another center in South India, what has happened is like a lady post mastectomy here, she had some breast cancer, if I can remember right. She had some incoordination. That was the case. It came in actually in station 5. All right. So, what is it? This is typically a paraneoplastic syndrome. All right. Typically, you will find in lung cancer, especially small cell carcinoma, the cancers of the breast, lungs, and as well as uterus, ovary, and some Hodgkin's lymphoma. What will be there is there will be high titers of antibodies. Next thing they will ask you, what kind of antibodies you will find in case of a paraneoplastic syndrome. There are two antibodies you have to tell. One is anti-yo, that is anti-Purkinje cell antibodies. All right. This is typically seen in gynecological and breast cancer. And anti-HU, HU, these are anti-neuronal and nuclear antibodies. This is seen typically in small cell lung carcinoma and some sarcomas, some prostatic carcinoma, and as well as some neuroblastoma. All right. Then when it comes to this paraneoplastic cerebellar degeneration, what are the things you will do? You will just have to tap and take the CSF. You will find high titers of antibodies. All right. Okay. This cross react with the nerve system cells, the neurons, and then leading to this cerebellar degeneration. So the first thing, you treat the underlying cause, give the supportive treatment. That's all the only thing you will do. All right. I hope that helps.
Yes, doctor, for sure. So thank you for all the information about this paraneoplastic cerebellar degeneration as well, because the name itself is a quite lengthier one. It gets a bit confusing to a lot of
Yeah,
people.
absolutely. Yes,
Yeah,
exactly.
thank you on that.
All
So how
right.
does acute case with cerebellar dysfunction presents? Like, does
Okay.
it get any confusing to examine and arrive at the diagnosis in acute versus the chronic presentations?
Mhm. In acute case, if you see acutely somebody presenting with the cerebellar findings in India, I look at the patient's age. He never had any such symptoms and maybe developed over a course of hours to days. The first thing I will rule out, is there any posterior circulation stroke or any cerebellar stroke is there? First thing I'll rule that out. And next thing in India, above all, more common is an alcoholic cerebellar degeneration. All right. So these are the two things you have to rule out immediately because anything else will start over the period of time. That won't all of a sudden become a cerebellar syndrome. And multiple sclerosis, if an acute attack is there, they can present like that. and any brainstem lesion you have to rule out. So these are the acute causes. So once you find something acute as an acute cause, then you have to give the differential diagnosis of an acute cause. All right, you cannot go ahead and put a differential of. That's what many people confuse themselves and confuse the examiners as well. All right, there would be some acute cause of cerebellar syndrome, like some alcoholic cerebellar degeneration. There this gentleman will go ahead and tell this is some von Hippel-Lindau syndrome, some spinocerebellar ataxia. No, 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 that's not the thing. If it is an acute, give the differentials of acute. So these are some of the common acute cerebellar presentations. So once you get an acute cerebellar differential presentations, you give acute cerebellar differentiations, like what are the differentials, which I told you now, then you will be safe. So most of the acute cases, things like alcohol can be reversible to up to many extent. Like you have to just talk at that point about the alcohol avoidance as a part of the management. Okay, because that will be again noted in clinical judgment. If it is alcoholic, he has to stop alcohol. In UK, he has to be referred to an alcoholic anonymous group. That is very important. If you're suspecting drug, you have to tell the drug has to be tapered out or discontinued after a talk with the neurologist. So these are very, very important. Chronic conditions, what are all the chronic conditions? Can be again demyelinating, posterior fossa space occupying lesion, can be Friedreich's ataxia. Even there is another condition called ataxia telangiectasia. Here, suppose if they are bringing such a scenario in station 2 and 5, you will also note the patient may be having frequent infections because due to depressed immune system. So there will be associated frequent infection. Hypothyroidism is a condition that can also present with cerebellar findings. There is another condition called A beta lipoproteinemia, again can present with cerebellar findings. These are some things which we need to know about acute and chronic cerebellar syndrome.
That was a great explanation, doctor.
Thank you. Thank you so much. Yeah.
So, doctor, is it possible to clinically localize a cerebellar lesion?
Oh yeah, clinically to localize. Nowadays, most people are not at all relying a clinical diagnosis because most people are typically more than happy to deal with MRIs, but clinical examination still holds the key. I'll tell a couple of things. Okay, it may not be so exactly appropriate, but if there is a lesion in a paleocerebellum, all right, okay, there will be inability to perform a tandem walking. Gait ataxia will be more. Okay, because it is associated with anterior lobe involvement. If there is a truncal ataxia, all right, or maybe some titubation, the head bobbing movement, then most likely there will be either a flocculonodular lobe or a posterior lobe involvement. Then it has to do with archicerebellum. If there is a limb ataxia, especially in the upper limbs and also some hypotonia of the upper limb, if you're finding that, then the lesion could be in the lateral lobes, that is your neocerebellum. These are the three ways you can clinically localize at an MRCP level.
Okay, that's a lot of information today that we have discussed, and I'm sure that our candidates have gotten a maximum benefit, and they are now able to even approach the case with cerebellum and to come to the conclusion, to know the causes, steps, the culprits causing the cerebellar dysfunction, acute cases, paraneoplastic. So there were a lot of topics that we discussed today, and I'm sure that the candidates are quite aware of everything about the cerebellum.
Absolutely. And one more thing that can be asked is, what are the difference between a sensory ataxia and a cerebellar ataxia? If they're asking, suppose the site of lesion, for example, in a cerebellar ataxia is a cerebellum. In case of a sensory ataxia, it's a dorsal column. And when it comes to deep tendon reflexes, in cerebellar, in the knee reflex, it will be pendular. In sensory ataxia, it will be lost or diminished. And sphincter disturbance will be there in case of, posterior column involvement, overflow incontinence, like that can be there. All right. So these are a couple of things. And also sensory loss, deep seated sensory loss will not be there in cerebellar ataxia. It will be there in a case of a sensory ataxia. That's very, very important. All right.
That was a great discussion, Dr. Moses. Thank you so much for sharing all the knowledge and information that our candidates need to prepare for the neuro station. Thank you so much.
All right. Thank you. Thank you so much. And I hope this helps. And one more thing, finally, if they ask you about the investigation, you have to tell pertaining to the cause. For example, if you are dealing with a subacute combined degeneration of the spinal cord, you have to talk about vitamin B12 levels and as well as MRI. Especially, you will find something called inverted V sign. All right. And if you're dealing with a multiple sclerosis, again, MRI, then you have to talk about CSF studies, oligoclonal bands, visual evoked potentials, and you have to also rule out any NMO by checking anti-aquaporin 4 antibody levels. Alcoholic cerebellar degeneration, you have to definitely mention about liver function test and ALT-AST reversal. Okay, that's very, very important. And again, if you're dealing with Friedreich's ataxia, spinocerebellar ataxia, then you have to talk about genetic studies. All right, that's very important. Also, you have to talk about thyroid function test to rule out any hypothyroidism. And for paraneoplastic cerebellar degeneration, we already told the investigation. So the management entirely depend on what is the cause. All right, that's one of the thing I felt like it's important to add up to the today's discussion. Yeah, that's it.
It's definitely, Doctor. Thank you so much for sharing us the information about the investigations, management, everything a candidate should know about the cerebellar syndrome. So thank you so much for today's session, Doctor. Thank you so much for sharing a lot of information.
Thank you. Thank you so much. It's a pleasure to be here. And again, we will meet up with another session of cerebellar syndrome. Like today, we will be doing another session sometime later. Thank you.
Doctor, looking forward to get more information and knowledge from you. Thank you so much.
Thank you. Thank you. Thank you so
For
much,
having
Doctor.
you here, Doctor. And for those who haven't listened to our previous discussion on introduction to neurostation and spastic paraparesis, please visit pacesdiaries.uk and listen to our podcast series. Thank you so much.
Yeah. Thank you. Thank you so much, Doctor. Thank you.